Hello and welcome to the Intern Bootcamp for Hepatitis. This is going to be a shorter lecture and this is really kind of just a review for you. Not many things that we can do with hepatitis in the clinic, but unfortunately the once non-treatable hepatitis C is now fortunately treatable. So we are actually starting to move forward with hepatitis C treatment, and we have a Hep C clinic based on a grant here at LSU, and eventually it'll be pushed out to primary care per the AAFP guidelines. So what is hepatitis? Well, hepatitis is consistent of A, B, C, and then we have our autoimmune hepatitis as well. But in that, we also have hepatitis D and E that are going to be important for various other things. This is a great slide that someone drew, and I guess in medical school to figure out how to do and remember these things. But it's a good thing for you to kind of remember of how things are spread and how we treat those spreads, and do we need to treat anything with them. So let's talk about the types of hepatitis. We will have one question on your step 3 about hepatitis, I'm sure of it. A and E are spread by feces and fecal to oral, people not washing their hands, or soiled drinking water in this case. And then B through D are all the percutaneous permucosal blood or bodily fluid. And so you'll see here that B, C, and D all cause chronic infection. And you'll notice right here we have a immunization for A, B, and D, and then we have treatment for C now. So we've been able to conquer this. A, E are self-limiting, D is also self-limiting, B and C both cause chronic infection, and C for cancer. C is the bad one. So let's talk about the kinds of virus. I think I saw maybe one question about what is the type of virus that you have. Well, I never really was able to memorize all this stuff, but what I was able to remember is that hepatitis is liver. Liver is going to cause problems with your clotting, going to cause you to have systemic symptoms. You're going to see bumps in your AST or ALT, and more importantly, what happens when E and A are both fast. That's why you can think of them as ingestion and self-limiting. You're going to be able to see them by IgM antibodies, which are acute markers. And then you have chronic, which B, C, and D. They're going to take longer times for incubation and then for our expression of that virus. We already know that all of these are parenteral or bisexual contact. And you'll notice every one of these but the Hep C is going to be an IgM diagnosis. The other ones are all IgM, whereas Hep C is going to be a PCR viral RNA. So when you order a Hep C screening and it's going to be antibody positive, it reflexes to the viral load. And so if it doesn't, then you need to be aware that that is something that you need to do, because you can have cleared a hepatitis C virus, and if your antibodies are positive but your viral load is negative, then you've cleared it yourself. If you haven't, then you need to start on the direct acting therapies, the DATs. So Hep C causes cancer. Hep B does also still cause cancer, but is not as prominent as Hep C. Hep D can cause severe liver damage and high mortality rate, and D goes with B and C goes with E. So I think that's the way it goes. But whenever you are thinking about this, anytime a woman is pregnant and have hepatitis, you need to run the hepatitis E and the PCR viral RNA, and that's really important for OB. It does show to have an increased risk of mortality and morbidity, but it does not occur as a chronic liver disease. So understanding that your Hep B, C, and D are really the ones, and really Hep B and C are the ones that you really want to look for. And this is the one that the best practice and the AFP really wants you to be concerned about is Hep C. You should do this once in a lifetime because we do now have a treatment for it. 5 years ago, that was not a US PSTF guideline because of the fact that we didn't have treatment. So Hep A, there's no formal treatment. It's self-limiting. It'll die on its own. It'll be okay. Hep B, there's no exact treatment, and most people get better within 1 to 2 months. So that's the common consensus by up to date. Now there are instances where you can use antibodies for this treatment, but that's really for an acute fulminant hepatitis B infection that people really need treatment for. Hepatitis C, confirm with the quantified, and then in our clinic you're going to clinic refer them. In the oral and the boards themselves, it's going to be direct acting therapy, and those are going to be our VEERS. and you take that for 6 to 8 weeks, and then they clear. You do a confirmatory test with Hep C quantified several months later. If they have persistently stayed viral negative, then you're good to go. You can just kind of do surveillance every once in a while and make sure they're still not having a resurgence. Now, if they're still Hep C positive after therapy, then that needs to go to the hepatologist, because they're going to be the ones that are going to need to continue treatment. There used to be with DAT is that there was one form which was a lot more caustic. It was very hard on patients that had low patient compliance because of the fact that it caused so many side effects. Now with the pills, it's very limited side effect profile, and so therefore patients are much more likely to comply. Hepatitis D, no recognized treatments for acute or chronic. Like we saw before in the previous slide, it does have an increased risk of morbidity and mortality. So if you do have hepatitis D, it's going to need to be a close one-to-one observation and making sure that you manage the patient supportively. Hepatitis E with acute illness and pregnant women, you're going to use ribavirin for 21 days. That can be pretty hard for a pregnant woman or a man, period. Ribavirin does have some side effect profile. Then our healthcare maintenance hepatitis panel once in a lifetime. Some will say just Hep C alone. That's fine too, whatever. And you can see right here, we can just do it once in a lifetime. If you have an unplanned sexual encounter, it's going to be a hepatitis panel. In addition to that, we already talked about what happens when you treat and after you treat Hep C, and making sure that with our special populations like pregnant women that you're adding a hepatitis E IgM if you do have a concurrent B or C infection. All right, well that concludes